Hi, my name is Leah Halali. I'm a professor of neuroradiology at the Barrow Neurological Institute. I would like to thank Philips and the American Society of Head and Neck Radiology for the opportunity to speak to you all about MR neurography of the craniospinal nerves below the skull base. I have no disclosures. MR neurography at the skull base is much different than MR neurography elsewhere. So we'll begin by talking about the technical considerations necessary to be able to apply MR neurography techniques to the very small nerves that we image at the skull base. I'll talk about how we at the Barrow Neurological Institute use MR neurography for pain syndromes, as well as how we are currently developing it to be used for preoperative planning for skull base surgery. So let's first begin with a little bit of background about MR neurography. So peripheral neuropathies are a very heterogeneous group of disorders. They can be traumatic, they can be non-traumatic, and in the non-traumatic category, there are many different etiologies. It is very difficult to work these up, especially because the EMG findings are relatively non-specific, and even after extensive workup, many of these patients still carry a diagnosis of idiopathic peripheral neuropathy. MR neurography was brought as a solution to try to delineate what was behind many of these, quote, idiopathic cases. Unfortunately, when MR neurography first began, all we could really tell clinicians is whether or not there was something external pressing on the nerve. However, as our MR techniques have advanced, we can now image intrinsic pathology of the nerve itself. I like to think of MR neurography for nerves as analogous to MR angiography for the arteries and veins. Basically, it's any technique that seeks to make the nerves more conspicuous by trying to get rid of background signal and to image at a high resolution to be able to see pathology. So what do we need in order to make an MR neurography sequence? So it's basically the same idea as what we're trying to do when we do an MR angiogram. We're trying to get rid of everything except what's of interest, and for MR neurography, that's nerves. So we start off with a T2 weighted image because the nerves are very bright on T2. Then we try to get rid of the background first by getting rid of the fat with a fat saturation. Then we get rid of the vessels by doing a black blood technique, and essentially all we're left with is nerves and a few small lymph nodes. So while those principles serve us very well when we're imaging large nerves such as the brachial plexus, unfortunately they just don't have the spatial resolution to be able to see the tiny nerves that we need to see in the skull base. So therefore, a new technique has been developed, which is a 3D time-reversed fast imaging with steady-state free precession. It's called a reverse FISP, which is the brand name for Siemens. So because it's a reverse, they call it a PSIF, which is a reverse of FSIP. So the question is, since this is a Philips talk, should this be called an F? Since the same Fiesta sequence or FISP sequence, it's called an FFE on Philips. But these sequences have the ability to give us the background saturation, but also the spatial resolution necessary to be able to image these very small nerves. Our MR neurography protocol for the skull base has several requirements. First, you need to do it on a 3T. You just need better fat saturation, and for imaging time to have the kind of resolution that you need for these studies, doing it on a 1.5 simply isn't practical. The patient will not be able to sit still for the imaging time. We use a 32-channel head coil. We get 0.5 millimeter isotropic images, and doing this on a 3T, that's about a 6.5 minute acquisition. It's very important that you be able to reconstruct these images on a separate 3D workstation to be able to really do the multiplanar curved reconstructions to be able to follow the course of these nerves because the course can be very complex, and being able to line the nerve out along its course is very important for being able to look at pathology. We also include axial T1 weighted images and coronal stir images to look for both any incidental findings, right? Maybe they have things in addition to their peripheral neuropathy, as well as to look for secondary signs related to the peripheral neuropathy, such as muscle atrophy. As I mentioned, the multiplanar curved reconstructions are very important. This is an example of what I do literally every time I read and study for occipital neuralgia. Is you want to be able to trace out the entirety of the occipital nerve, and you want to be able to lay it out along its course using 3D reconstructions. So we tend to use it mainly for craniofacial pain syndromes. Traditionally and most commonly, we do it for the trigeminal nerve. This is usually the easiest also because it's the largest nerve, but it can also be used for glossopharyngeal neuralgia or occipital neuralgia, which we commonly do as well. More novel uses for MR neurography include uses for more uncommon pain syndromes, such as Vidian nerve pain syndromes. We also have been trying to incorporate it in preoperative planning for lesions at the skull base, as well as lesions that involve the parotid. And it may also be used in patients to look more accurately for very subtle signs of perineural spread of tumor, especially in those who can't receive contrast material. So let's talk about how we use MR neurography for pain syndromes. So first, you have to understand what nerve injury looks like on MR. The most commonly used classification system is the Sunderland classification, and this has corresponding findings on MR neurography. So class 1 is what is kind of like a nerve bruise, that there's a conduction interruption, there's some myelin injury, but the nerve itself is intact. And for this, you'll just see increased T2 signal in the nerve, and the muscle itself will be normal. For class 2 and 3 injuries, there is loss of the continuity of the axon, but the covering, the perineurium, the epineurium is preserved. I think of this kind of like a dissection in the arteries. There is interruption of the important endothelium or inner part, but there still is the media and interstitium around it. So for this, you'll see, again, the T2 signal, and you may see enlargement, similar to what you may see in a dissection in a vessel, and you'll also see denervation changes in the muscle. For a class 4 injury, only the epineurium remains intact. And I think of this kind of like a pseudoaneurysm on MR angiography. So you'll see focal enlargement of the nerve in that region, similar to a pseudoaneurysm, and you will, of course, see denervation changes because the nerve itself is disrupted. Class 5 is complete disruption, severing of all of the nerve and associated supporting tissues. And you usually will get an end bulb neuroma. And then, of course, because there is such a severe injury, you also have the muscle denervation changes. So let's talk about some specific nerves that we look at and the pathologies that are associated. As I mentioned, we most commonly image the trigeminal nerve for facial pain syndromes because it's the most commonly involved, as well as, luckily for us, the easiest to image because of its large size. So the trigeminal nerve is both sensory and motor. It comes from the pons and exits through Meckel's cave, where it trifurcates into the 3 divisions, the ophthalmic, maxillary, and mandibular division. The ophthalmic division exits through the superior orbital fissure, where it gives off the frontal, lacrimal, and nasociliary branches. It further divides in the frontal region into the supraorbital and supratrochlear nerves. And basically, this provides innervation to your orbital region as well as your forehead. So you can see that not only can we identify the ophthalmic nerve itself, but we can actually see its branching. You can see here how the ophthalmic nerve is branching into the frontal nerve and the trunk that gives off the nasociliary and lacrimal nerves. Also in this image, you can see the ocular motor nerve along the inferior aspect of the superior orbital fissure. So when we look at V1, it's not usually commonly associated in trigeminal neuralgia per se, but it can be involved with infection, especially of the sinuses, perineural spread of tumor, especially for skin tumors around the eye. It is relatively rare to have a schwannoma in the region of V1. Next is V2, the maxillary division. It goes out through foramen rotundum into the pterygopalatine fossa. There, it gives off branches to the maxillary alveolus, which is the alveolar and palatine nerves. And then it travels along the inferior orbit as the infraorbital nerve, where it gives sensation to the midface. Our MR neurography with our Philips scanner gives us high enough resolution that we can actually identify the pterygopalatine ganglion within the pterygopalatine fossa. You can see here the palatine nerve extending inferiorly from the pterygopalatine ganglion. We can identify the infraorbital nerve along its course as it extends to the soft tissues of the mid. Amazingly, we actually have the resolution to identify each individual branch to each tooth along the maxillary alveolar ridge. And I actually showed these images to one of the neurosurgery fellows who works in the dissection lab, and he was absolutely amazed. He said to me, "This is what I see." We actually have the ability to essentially do a dissection non-invasively using these MR neurography techniques. Processes that affect V2, again, similar to V1 because it's in the region of the sinuses, it can be affected by aggressive sinusitis. It is not uncommon to see involvement of V2 in perineural spread of tumor. And of course, in trauma, especially with orbital blowout fractures that affect the infraorbital nerve, you can have injuries to V2. Similar to V1, it is rare to see a schwannoma in this region. Finally, there's V3, the mandibular division, which is a mixed sensory and motor nerve. It provides innervation to the muscles of mastication as well as sensory to the lower face, ear, and TMJ. So initially it gives off a tiny anterior motor branch, and then the larger posterior sensory branch divides into the auriculotemporal, lingular, and inferior alveolar nerves. And we actually have the ability to see each one of these. So the auricular temporal is, as it sounds, going to supply the sensation to the TMJ. The lingual nerve, again, like its name implies, is going to be supplying sensation to the tongue. And the inferior alveolar nerve does have a motor branch for the floor of mouth, but then involves or innervates the sensory fibers for the gingiva and teeth of the mandible. So we can actually see each of these individual branches of V3. Here you can see an anatomic drawing, and here you can see the corresponding MR neurography showing in perfect detail the branching of the auriculotemporal to go to the TMJ and the two main branches of the lingual and inferior alveolar nerves. Here it is on a sagittal image. You can see here the lingual nerve branching away from the inferior alveolar nerve, which is going to be entering the mandibular canal. So processes that can affect V3, again, because it's involving the mandible, obviously odontogenic infections. Again, the inferior alveolar nerve may be affected for any process that causes injury to the mandible, be it fracture or osteorated necrosis. What we commonly see is injury related to tooth extractions, but again, it is in the region that squamous cell carcinoma may involve it, related to perineural spread of tumor. And again, nerve sheath tumors are very rare for V3, similar to V1 and V2. Here's an example of an injury that we see commonly related to a molar tooth extraction. This patient had a 5-month history of eating and chewing difficulties and paresthesias after they had a third molar removal. And you can see here that the inferior alveolar nerve on the right side where she had the tooth removal is enlarged with increased T2 signal compared to the left. And this is consistent with a Sunderland type 1 injury. This is another example. This was a 71-year-old woman who initially started to have pain after a molar extraction that just continued to progress. And you can see here that she was worked up extensively since 1997 even, with multiple CT examinations of the face, of the sinuses, MR examinations, and no one could find the source of this poor woman's pain. We finally did an MR neurography on her, and we saw an injury to the inferior alveolar nerve. So here you can see that there is thickening of the proximal portion of that inferior alveolar nerve, which is consistent with a focal neuroma, and then it's thinned and nearly disrupted distal to this region. Here you can see the normal course of the inferior alveolar nerve. So this was actually a class 4 injury to the inferior alveolar nerve caused by her dental extraction. We can do imaging of the Vidian nerve, which is involved in more autonomic type pain syndrome. So you can see that our MR neurography technique on a Philips scanner can identify the Vidian nerve, this tiny, tiny nerve within the Vidian canal. Above it, you can see here is V2 in rotundum. So really, it's opened up the possibility of being able to visualize structures that we've simply had to infer previously. We do a lot of work for occipital neuralgia. We have a large headache clinic at our institution. So we can image the greater occipital nerve, which arises from the dorsal ramus of C2 and rises along the dorsal aspect of the calvarium to give sensory supply to the occiput. It is more difficult to visualize consistently the lesser and least occipital nerve as these are much smaller in caliber. So here you can see the greater occipital nerve being traced from its origin from the dorsal ramus of C2 extending along the suboccipital region to supply sensation to the dorsal aspect of the skull and scalp. Here you can see it being traced even further. So commonly the occipital nerve is affected through compression points, and at our clinic they do therapeutic blocks and Botox treatment, but they can do decompressive surgery for patients who do have compression points. But the reason that they need MR neurography in these patients is they want to be able to make sure that it is unilateral disease, that when they operate that they will be successful. So they want us to be able to say that there is pathology on one side and not pathology on the other. Additionally, if they continue to have pain post-surgery, we may be able to identify some sort of injury such as a neuroma. Another application that we're trying to develop even more at the Barrow is using MR neurography for preoperative planning. So one of the most difficult regions to operate on is the parotid because of facial nerve injury. And we have been developing this technique together with our otolaryngology colleagues to help them to better plan their parotid surgeries. So the facial nerve is predominantly a motor nerve, though it does carry some parasympathetic and sensory branches. So it exits through the stylomastoid foramen and then gives off the posterior auricular branch and then divides into its two major branches, the temporofacial and cervicofacial branches. We can see this division. You can see here going more superiorly the temporofacial branch. You can follow it all the way down as it exits the stylomastoid foramen and then turns and goes superiorly. And then you can also see it going more inferiorly for the the cervicofacial trunk. So the temporofacial and cervicofacial divisions then divide into what we traditionally think of as the branches of the facial nerve, right? We all learned when we were in medical school to Zanzibar by motor car. So the temporal, zygomatic, buccal, marginomandibular, and cervical branches. So we can actually see each of these individual branches and their own division. So here you can see the branching of the zygomatic nerve. Here you can see it just along the zygoma. We can actually see its distal terminating branches in the subcutaneous soft tissues just below the dermal surface of the face in this region. Here we can see the buccal branches going along the cheek. One of the most important branches, especially in parotid surgeries, and one of the most commonly injured nerve in parotid surgery is the marginal mandibular branch. And here you can see the marginal mandibular branch with its branching pattern exactly as we see on the anatomic model. Again, the reason that we're trying to develop this MR neurography of the facial nerve is to try to prevent iatrogenic injury during parotid surgeries, and that's why our ENT colleagues are very invested in this. It can also be used possibly to trace perineural spread, especially if it's very distal within the parotid. You may be able to detect abnormalities in very tiny branches that wouldn't be seen on traditional post-contrast T1 weighted images. We are also very interested in applying this technique to preoperative planning for skull-base surgeries. We have a very large skull-base tumor surgery program at the Barrow Neurological Institute, and we would like to help our clinical colleagues to be able to plan surgeries at the skull base with better assessment of risk to neurologic structures. So here we have an MR neurography image at the skull base and a corresponding anatomic diagram. So you can see that we can actually identify each of the individual nerves at the skull base seen on this diagram. So first we have the glossopharyngeal nerve. You can see here it exiting through the jugular foramen and extending inferiorly along the lateral aspect. We can also identify the vagus nerve in the region of the jugular foramen. And in fact, we can actually see its branching. So here you can see the vagus nerve, and it gives off initially the auricular branch of the vagus. Also, we can see the hypoglossal nerve, which is exiting the hypoglossal canal and then entering with the lower cranial nerves into the carotid space. We can actually trace it all the way down as it enters into the region of the tongue. This technique allows us not only to visualize the traditional cranial nerves at the skull base, but also things that we have never seen before, such as the sympathetics. We can actually visualize the superior cervical ganglion, which we believe in time will be able to help us identify many problems with autonomic dysfunction that may otherwise remain idiopathic. We can also identify the tiny accessory nerve going along the region of the sternocleidomastoid and into the region of the trapezius musculature. This is very important because the most common cause of an accessory nerve injury is actually an iatrogenic injury from a percutaneous lymph node biopsy in this region. So if we are to apply this to patients who are getting lymph node biopsies and be able to tell the interventionalist the relationship of the lymph node that they're looking at to the accessory nerve, we believe that we may be able to prevent a significant number of accessory injuries. So, of course, I would like to acknowledge Philips Healthcare for giving me the opportunity to speak on this subject, as well as for providing the technology that makes this kind of MR neurography possible. I would like to thank also Z. King Lee. He's one of the Philips MR research scientists that helped to perfect the image quality. And, of course, I would love to thank my clinical collaborators, Andrew Little, who is our skull-based surgeon, as well as Griffin Santorelli and John Milligan, our ENT colleagues, who are helping to develop new and novel ways that we can use MR neurography at the skull base. Thank you very much.